Hi, I'm Ann Eglash, a family physician and a board-certified breastfeeding medicine specialist in Madison, Wisconsin. I'm a clinical professor at the University of Wisconsin School of Medicine and Public Health, and I'm also the CEO of IABLE, the Institute for the Advancement of Breastfeeding and Lactation Education.
Hi, I'm Dr. Lena Edelstein. I am certified by the North American Board of Breastfeeding and Lactation Medicine, a board-certified pediatrician, and international board-certified lactation consultant. I care for breastfeeding diets in private practice in the outpatient setting.
Hi, Lena. How are you?
Hi, Anne. I'm doing great. How are you doing today?
Good, good. Looking forward to talking about breastfeeding stuff.
Yes, as always.
Yeah.
Well, today I will be talking about an integrative review titled The Effect of Magnesium Sulfate in the Treatment of Maternal Postpartum Hypertension on Breastfeeding. An integrative review, and this is by Holiday Solly, Rebecca Clark, and Diane Spatz.
And I want to tell you that I met Holiday at the Human Milk Institute conference recently in March of 2026. And I just want to give a shout out to her because she's amazing, and congratulations on this study.
Oh, yes, congratulations, Holiday. So let's start with some quick context. Hypertensive disorders of pregnancy cover a spectrum of conditions, including gestational hypertension, chronic hypertension with superimposed preeclampsia, and eclampsia. And in the United States, these disorders complicate more than 15% of pregnancies and are linked to nearly 1/3 of maternal deaths during delivery hospitalizations. And very importantly, the risk doesn't just end postpartum for these women. These patients carry a 2 to 4-fold increased lifetime risk of developing cardiovascular disease. I was shocked by that statistic.
That's really interesting. Yeah.
Yeah. So this is where lactation becomes especially relevant. Breastfeeding reduces the risk of preeclampsia in future pregnancies and offers long-term cardiovascular protection for the mother. So from a clinical standpoint, supporting lactation in this population is really critical.
Yeah, that is a really great point.
So for patients with severe preeclampsia, the standard of care includes intravenous magnesium sulfate, which is highly effective for preventing and treating eclamptic seizures. Its mechanism of action is that it acts as a central nervous system depressant and a vasodilator, but those same mechanisms drive its side effects as well: flushing, nausea, vomiting, and notably fatigue and sedation. And these effects are dose dependent at higher infusion rates, like 2 grams per hour. It was reported that over 70% of patients experience side effects, as compared to 25% of patients experiencing side effects at a rate of 1 gram per hour. So here's the thing though, magnesium sulfate, it's typically administered during a window that overlaps with lactation initiation. And that early postpartum period is when frequent and effective breast stimulation is essential. This is even before secretory activation occurs. And it's those first feeds with colostrum. It's when those first feeds with colostrum are happening. So
Right.
the question becomes, and what these authors were looking for, is to study how does magnesium sulfate therapy affect breastfeeding?
Mm-hmm.
A quick historical note. I looked this up on my own just because I was wondering about how treatment with magnesium sulfate even got started. So it's been used for preeclampsia since the early 1900s. And management strategies for preeclampsia and eclampsia haven't changed dramatically since the 1960s. So the protocols have been refined over time, but the core approach, whether it's monitoring the mother, giving antihypertensives, seizure prophylaxis, and then planning the delivery, that overall largely remains the same since the introduction of magnesium sulfate.
That's so interesting. Yeah, I've used
Yeah.
it my entire career, so yeah, it's a long time.
hmm So we also know that intrapartum magnesium can affect neonates, causing hypotonia and feeding difficulties. But postpartum IV magnesium sulfate has minimal impact on breast milk magnesium levels and low oral absorption in infants. So this review set out to synthesize the evidence out there specifically on magnesium sulfate treatment and lactation outcomes.
Mm-hmm. And I
So
just want to say that the assumption before you drum roll, to hear what she found, I would say that from like the way that we talk about it thus far, we always assume that when people get IV mag for preeclampsia postpartum, that their milk is going to be delayed, that it causes a delay in secretory activation.
well, we will get there.
Right.
Okay. So
That's the word on the street, right? So it's good to have studies to sort of, back that up or not back it up. Yeah.
yes, yes, definitely. So the authors conducted a structured search across 5 databases in May of 2025, and they focus on studies that evaluated magnesium sulfate use in patients with a hypertensive disorder of pregnancy and reported at least one lactation outcome. The search terms they used included breastfeeding, lactation, milk expression, secretory activation, and magnesium sulfate. Eligibility criteria included that the study was conducted with human participants. They reported IV magnesium sulfate therapy administration for the prevention or treatment of eclampsia amongst women who were diagnosed with a hypertensive disorder of pregnancy. They had to examine at least one lactation outcome, for example, initiation, frequency, duration of breastfeeding, milk expression, pumping habits. It was primary research published in a peer-reviewed journal, and the study was available in English. So out of 590 unique studies identified with their search, only 11 studies met inclusion criteria, and the research was spanning from 1993 to 2023. So these included a mix of study designs, 3 randomized controlled trials, 4 retrospective cohorts, a cross-sectional study, a case series, and 2 case reports. All in all, in total, about 2,800 women were represented, and most with severe preeclampsia, which, yeah, it makes sense, right? Because a patient isn't going to be getting magnesium if their symptoms aren't severe or they're not having severe features.
Yeah.
Where were these studies from? 6 were from the United States, 1 was from India, 1 from Mexico, 1 from Pakistan, and 1 was broadly given the term Latin America. Demographically, patients were typically in their mid-20s to early 30s, predominantly primiparous, about 55 to 65%, and often they delivered between 36 to 37 weeks. So at late preterm or early term gestational age, although some of the case reports and case series had mothers who were delivering later, like further towards term. Cesarean delivery rates were notably high, between 52 and 75%, and NICU admission rates, when reported, ranged from 44 to 58%, which is far above national averages for NICU admissions, around 9.8%. But most of the studies did not report on the rates of NICU admission. Most of the studies involved patients receiving a standard 24-hour postpartum magnesium infusion, usually at a rate of 1 to 2 grams per hour. Pre-gestational or gestational diabetes as a comorbidity ranged from 2.3 to 15%, except for 1 study where the focus was on a population with diabetes, where 70% of their population had some form of diabetes.
Mm-hmm.
BMI was inconsistently reported. Generally, it was within the overweight to highly obese range. But in the studies, even where it was reported, it wasn't necessarily noted when the weight was measured. So again, limited reliability with that factor. And now that we described our population, let's get into the lactation outcomes.
Mm-hmm.
So first off, the definitions varied widely across the studies. Breastfeeding initiation could mean direct breastfeeding, pumping, any provision of human milk. Success, how do you want to define success? Ranged from any breast milk exposure to exclusive breastfeeding at discharge, and exclusive breastfeeding, again, wide range of what exclusive breastfeeding could mean. But despite that variability, a few patterns emerged. First, the timing of initiation. So this I found to be really shocking, this result. Shorter magnesium exposure, and they considered magnesium exposure to be 6 to 8 hours, or if no magnesium was given, it was consistently associated with earlier breastfeeding initiation. Fine, okay. How much? Initiation occurred 8 to 12 hours earlier compared to those who received a standard 24-hour protocols, but 8 to 12 hours, that's like half a day. That's a
Yeah,
complete shift change. That's a day to night. That could really be of huge significance.
yeah, definitely.
Um, what I thought was really of interesting and of note is that in some of the case reports, the initiation times were closer to 30 to 90 minutes postpartum. So you wonder what was happening with a very much more focused case report as opposed to a larger N study.
Mhm.
Even when intention to breastfeed was high, actual initiation was often delayed. Only about 16 to 18% of patients initiated within the first hour in one study. Um, Up to 40% had delays beyond 7 hours. And separation, it likely played a major role with regards to timing of initiation. Mothers receiving magnesium in another study, they remained in labor and delivery or in a high acuity unit for the entire 24 hours of magnesium sulfate treatments. And a significant proportion of infants, especially in the cases where there were severe features, um, the babies were admitted to the NICU. So in 40% of the cases where it was preeclampsia with severe features, and even those without severe features, in one of the studies, 14% of the babies still ended up going to the NICU. So outside of the effect of the medication itself, this is like a structural barrier to breastfeeding. There's this separation going on.
Well, I'm just kind of going back to the initiation of breastfeeding being delayed with magnesium.
Mhm.
Do they separate out having a cesarean? Because that can cause delay as well? Or is it compared to like this is, it's not a description of all the patients, but it's like compared to those who didn't get magnesium. They're the ones who got magnesium, with other things being equal, they had a delay in initiation.
So your question about whether or not this is separating out those who had C-sections versus not, in the studies they have, if you look at the chart that they have within the actual article, each study it breaks it down what their strengths and weaknesses were, and for a lot of the studies, the strength was that they did take into account confounding factors, like
Okay,
if
good.
it was a
Okay,
C-section or not.
got it. Okay.
Um, so another outcome they looked at was feeding outcomes at discharge, and here the data is also limited. Only about half of the 11 studies included in this review reported on this. Exclusive breastfeeding rates ranged from 26% to 37%, with mixed feeding at 22 to 34%. And these rates were even lower for NICU admitted infants.
And then
Um,
a lot of these babies were, you said they were 36, 37 weeks because they were probably diagnosed with hypertension at that time in their pregnancy and just came in and got induced because of their hypertension. Yeah.
yeah.
So that's difficult. And if the question is, are they comparing them to term babies, to mothers who gave birth at term who didn't have preeclampsia, or are they compared? And you may not be able to tell me this because all these articles are different, right? But that's always a question who they compared them to. So,
Yeah. Um, One notable exception, it showed a much higher breastfeeding rate of 85.7%, which was actually higher than in this study's um, intention to breastfeed rate, which was 67.5%. Here, breastfeeding was defined by providing their own breast milk by any means. Even with this one study, which had this much higher breastfeeding initiation rate amongst this population who received magnesium sulfate, by the first week, 40, they were less than 50%. They were 49.5% who were still breastfeeding.
Hmm. Okay.
Um, and some studies provided long-term outcomes, but really not much. But one of the studies it looked out to who was it looked out to like the 10-day mark and were able to report that exclusive breast milk feeding was still happening at 10 days. But this was not in those larger studies that had larger ends.
Hmm.
So what about secretory activation? Two studies in this review addressed it, and both relied on maternal perception rather than objective biomarkers.
Hmm.
Reported timing of secretory activation, it ranged from day 4 to day 10 postpartum. It suggests possible delays, but we don't really have objective data here like the biomarkers of sodium or lactose content. Um, Milk expression practices were also inconsistently reported.
Well, the other
We,
thing too, assuming kind of going back to the timing of delay of onset of secretory activation, you said like 55 to 65% of these women were primips. And so that
Mhm.
again, the question is, assuming that that's all controlled for, yeah, not knowing if, for sure if it is. Yeah.
Was it due to them being Paris parents
Yes.
versus
Yeah. How much that.
the effect of having received magnesium sulfate treatments? Yes.
Prime nips who had a cesarean too. Yeah.
Right, right, right.
Yeah. Yeah.
So, back to the milk expression practices, we don't have clear information on necessarily the timing, frequency, or method of milk expression. So, whether these patients were using hand expression or single pumping or using a double electric pump. But for the studies that did report on milk expression practices, at time of discharge, 33 to 36% of patients who received magnesium were providing pumped milk. Only 9 to 10% were exclusively feeding pumped milk. So, one study was able to compare differences between when babies were going to either the well baby nursery or the babies were going to the NICU. So, for babies who went to the well baby nursery, 78% of babies had contact with their mom within the first 24 hours. For breastfeeding, um, 37 babies were able to feed in the first 24 hours, 23 babies fed on day 2, and 10 on day 3 or later. And at discharge, 33% of these babies were exclusively breastfed, 22% mixed fed, and 45% formula fed. In comparison, the babies in the study who went to the NICU, um, for these mothers, initiation of expressed breast milk was statistically significantly delayed comparatively and varied widely. So, 6 NICU babies received expressed milk on day 1, 24 on day 2, and 44 on day 3. At discharge, 26% were exclusively breastfed or breast milk fed, 23% mixed fed, and 51% formula fed. So you could see in comparison to these two groups, the babies who were able to go to the well baby nursery had it was much more skewed towards them initiating feeding earlier on as compared to the NICU babies, where you could see it was skewed much more towards a later initiation on day 3.
Hmm.
And again, in all of these studies, lactation support was sparsely described overall. Um, in some of the author studies, Cordero specifically, 77 to 87% of their sample did receive some sort of lactation consultation. And individualized support was provided in the smaller, like in the single case studies that were included in this review. So, what could we actually take away from all of this? At a really broad, high level, postpartum magnesium sulfate exposure appears to complicate lactation outcomes, particularly initiation and feeding at discharge. But we can't really isolate magnesium as the treatment itself as the sole cause. because these patients are dealing with multiple overlapping risk factors, as you were pointing out earlier. High rates of cesarean delivery, maternal infant separation, NICU admissions, and then institutional policies that may be in place that restrict breastfeeding during magnesium therapy. So the lactation challenges we're seeing are likely multifactorial. That being said, some of these factors are modifiable. So there's strong evidence that lactation support has a dose response relationship with breastfeeding success. So, preemptive, proactive, targeted lactation care, especially in this high risk population, it can significantly improve lactation outcomes. And this is where there's a lot of room for clinical practice to improve. So, hospital policies around rooming in, breastfeeding during magnesium sulfate therapy, and early milk expression support, all of these things matter a lot. Small changes like facilitating pumping within the first few hours postpartum, or I'm imagining my mind if an order is getting put in for magnesium sulfate therapy, that it also triggers a very structured lactation consultation to help support initiating lactation. And that having meaningful impact. So the authors highlight key areas for future research. One, using human milk biomarkers to identify when secretory activation actually happens, as opposed to relying on individual perceptions. Um, Documenting in detail methods of milk removal, behaviors around that. Qualitative exploration of maternal experiences, like what it felt like to need to be separate from their babies, symptoms that they were feeling, supports in place, and examining modifiable clinical and institutional factors. So, specific hospital policies, lactation support protocols, and magnesium sulfate dosing strategies that can be adjusted to hopefully optimize lactation, but still ensuring maternal safety.
Yeah.
So, to wrap it up, magnesium sulfate, it really remains essential for maternal safety in severe preeclampsia, but its use coinciding with this critical window for lactation and um, a potential combination of medication effects, which we really can't tease out, right? Like, is it the severity of the illness versus the application of the medication? And you can't really do an ethical study where we're going to say, hey, we're going to withhold this known beneficial medication just to see what would happen to lactation. It would be really hard to design a study like that. But um, systemic barriers that are in place can all disrupt breastfeeding as well. So the key takeaway I'm taking away from this is that we should anticipate these challenges and proactively support lactation in this high risk group, because they do have a tendency to have all of these other comorbidities going on. And there's certain things that we can control. There's things that we can't, but we can definitely help those who are anticipating separation, anticipating difficulties with initiating lactation, and giving them support to initiate that if they feel like they can't do it themselves.
Yeah, I think that's just it. It's just a marker. It's a marker for a really high risk population, because even gestational hypertension in and of itself, when they're not called preeclamptic and they're not on magnesium, that in itself is a risk factor for low production and delay in secretory activation. So some of the things that I hear from my patients when I get their history of when they they tell me their birth story, and they'll say, after I gave birth, I needed to be on magnesium. And I'll say, how did breastfeeding go during that time? Or were you pumping? And they'll usually say, I don't know. I was so out of it. I'm not sure what happened. I have a feeling I didn't pump. And then they'll look at their partner, and their partner will say, oh yeah, honey, I think you started pumping at like 12 hours or something. So I think the nail on the head when you said we need to support, I think that's it. Because I feel oftentimes that because breastfeeding is a choice, right? You decide how you're going to feed, there may be some staff who may feel like, well, I'm not going to push this person to pump because maybe they don't really want to. I don't want to be a lactivist or, be obnoxious about this. But I think that when someone's going to start magnesium, there needs to be the informed consent. Like, we know you might feel washed out. We know that breastfeeding or even pumping might feel uncomfortable. You may be nauseated, etc. How would you feel if we proactively helped you pump and your partner helped you and did some helped you with manual expression? How would you feel about that? Because that can make a big difference. And so really getting into the weeds with that person before they descend into that cloud of feeling awful may be really helpful. And so, yeah.
Definitely. And I mean, there's things that happen in medicine when people are not feeling comfortable, but we still push forward with things. I mean, even labor, right? Like labor itself is not a good, fun feeling thing
No,
for many people,
most, yeah.
but we move forward with it. And I think, like what you were saying, like people view lactation as optional,
Right.
as something that doesn't need to happen when it really is just an extension of what the next step of delivery is. And I think that really needs to be reformed as um rethought of as like something that like is supposed to happen. And even if things come up that make it a little bit more challenging, as long as the mothers are informed and consent and give their okay to let it happen, like we should really be able to support them through that, even
Yeah.
if it's
Yeah.
uncomfortable.
Right. And really just, yeah, definitely helping them and to understand that it's important. And I think that as more research comes out showing the extreme importance of colostrum in those first couple of days for innate immunity and shaping that acquired immunity, that hopefully over time we'll just stop using formula early on and just use mother's own colostrum, mother's own milk, and then donor milk if not possible. But I think that's really important. All right, well, let's switch gears and talk about zinc. We actually
Yes.
had an interesting case that was presented on the iAble listserv recently with a question about how do you work up or how do you identify whether or not low zinc levels are in milk. And I thought that was really interesting. And then an article came out through the PubMed search that you did. So I thought I'd talk about this. So the title of this article is Transient Neonatal Zinc Deficiency Due to Maternal Variants in SLC30A2. So that's the name of the gene. So there's this identifiable variant in the gene that can be associated with low zinc levels in neonates. And there's a couple different types. I'm going to talk about those. And the first author is Christopher Carter, and this was published in March 2026 in the American Journal of Medical Genetics. So the authors present a case of a breastfeeding infant who was diagnosed with a zinc deficiency, and they discuss how to evaluate the underlying cause, as well as some other issues just regarding screening. So just to step back, I want to just talk about zinc for a moment. Zinc is really a very important trace element in general health, particularly for newborns. Zinc is a cofactor that's involved in a lot of cellular activities, such as signaling, differentiation, proliferation, and immune function. And the symptoms of zinc deficiency are they generally kind of nonspecific, like this baby's is like not doing that great. So it can be skin lesions, like a rash, like just a generalized rash. It can be GI upset, like they're just kind of fussy. Maybe they act as if their tummy bothers them. They may have some growth impairment, which is more serious, and they may seem like they're kind of tired, which if those symptoms are mild and they have a mild zinc deficiency, it may be overlooked. And I'm going to talk more about that. And sometimes this is often not identified until the zinc deficiency is really severe. So causes of zinc deficiency. So whenever we think about any kind of deficiency, it's like you didn't get enough or you didn't absorb it or you threw it out, And in this case, it's going to be insufficient intake, like not having access to zinc in your diet, or it can be difficulty absorbing the zinc that's in the gut due to gut issues like inflammatory bowel disease. And then premature infants have a higher risk of zinc deficiency because they accrue their zinc storage, like their zinc accumulation happens as a fetus. And if they're born early, they're born with low zinc stores. So there are two infant conditions that I want to talk about associated with zinc deficiency. One is called acrodermatitis enteropathica, and I'm going to use the term AE. And then the other type is transient neonatal zinc deficiency, known as TNZD, just initials for it. But the two have different causes. So I'm going to talk about that. So they both can happen during infancy. And these infants with zinc deficiency present with the symptoms that I mentioned before: diarrhea, poor growth, irritability, fatigue, anemia, recurrent infections. And usually on exam, they have a pretty impressive rash. Some people may say it's eczema. In some of these babies, as it progresses, it looks more like large patches of psoriasis. They can also have nail changes and then sparse hair, even though like a lot of babies have sparse hair, but it's this wispy hair. And then they also have, they can have angular cheilitis, which is the rash that people get at the corners of their mouth. So AE is less common than the transient neonatal zinc deficiency, TNZD. AE is super rare. It only happens in 1 to 9 out of a million newborns. And this is due to a mutation in the gene SLC39A4. So that's a gene that codes for the zinc transporter in the gut. So because of that deformity, they just don't absorb zinc. And what's interesting is that it tends to be identified later in breastfed babies as opposed to formula-fed babies. So these babies can't absorb zinc, but they can absorb it better from breast milk because it's organically bound, as opposed to the inorganically bound zinc in formula. So they present later, particularly when they wean. So the other thing is that zinc levels are really high in colostrum, and then as time goes on, zinc levels drop in breast milk. And so that's why it kind of tends to be more obvious later, especially after weaning. But I think that's really interesting because, just as an aside, when you think about just evolution, zinc levels being much higher in colostrum, if maybe nature does this in a way with a possible assumption that the baby was born premature and is being born with insufficient zinc. So it's like, let's load them up with a little extra zinc just in case they didn't get enough during pregnancy. So that was interesting.
Yeah.
And then, so in comparison, the other way that these babies have low zinc levels, the transient neonatal zinc deficiency, the TNZD, that's more common. And that occurs in 1 out of 2,334 breastfed infants of mothers who are heterozygous for a mutation of a gene SLC3082. So the other one is SLC3984. So they're like, all these genes have these codes to them, right? So it's a different gene. And this is the one that causes acrodermatitis enteropathica. And these are the mothers that are positive for it. And this is the gene that codes for the zinc transporter that's responsible for the passage of the zinc into breast milk. So these mothers.
Wait. Let me just pause for a second there. So one of them is the baby can't get it, like you said before, whether it's not there to get or you can't absorb it. So one of them is they can't absorb it, and now this one sounds like it's not there.
It's not there. It's the mother's fault. It's the mother. And these mothers may have normal zinc levels. They don't have signs of zinc deficiency, but they can't transport it into the milk. And that's actually more common than the difficulty transporting it through the gut. And this form of zinc deficiency in infants is apparently less severe than the one where they can't absorb through their gut, because there still is some there's some zinc in breast milk. It's going to be low. There's going to be detectable, so they can absorb that. And they also might be getting some supplementation with donor milk or formula. A lot of babies do. So then they're going to be less severe. And then if they start solids early, and as soon as they start solids with zinc, it's just going to go away. So it's not going to be. It may totally fly under the radar. So it may be that this is actually more common in women than we're aware. The authors feel that this is an under-recognized disorder because the baby is usually the one who's evaluated for zinc deficiency. And so because the baby presents with low zinc. So then the baby gets evaluated with genetic testing, and the genetic testing is negative, and they're not thinking about testing the mother for this transporter problem. And maybe they'll say, oh, there's not enough zinc in breast milk. They might not even be testing the breast milk. They might be saying, oh, the breast milk's deficient or whatever, and like not really zeroing in on that issue. So anyway, in this article, they actually do a case presentation, and they talk about a 5-month-old who had a 3-month history of treatment refractory eczema and 1 week of poor feeding with irritability and a decrease in weight gain. He otherwise had been really healthy, no family history of skin conditions, autoimmune diseases, or any other conditions in infancy. He was a firstborn child, born at 35 weeks gestation without complications. And the prenatal carrier screening, which is the pregnancy screening, and the newborn screening were negative for any genetic problems. And then soon after birth, he got some donor milk for 3 days, and then he transitioned to maternal breast milk. So at 2 months of age, he developed a rash in the creases of his neck and on his scalp, and he was referred to peds dermatology, who presumed that he had atopic dermatitis. So he was on all these different like antifungal creams, and then a bunch of different steroid creams. And then mom thought it was related to her diet. So then she took out dairy and soy and gluten and nuts, and nothing really got better. And his rash continued to worsen. But at 4 months of age is when sort of everything hit the fan, and he was not as interested in feeding. He lost ground weight percentile wise. He went from the 2nd percentile to the 0.16th percentile. And then Derm took another look at this rash and said, this doesn't really look like eczema. This looks like it could be nutritional. And so then the baby underwent all these outpatient labs. And the most significant finding was that he had a low zinc level of 28 micrograms per deciliter, and normal 60 to 120. So because of the low zinc level, the medical genetics team was consulted. And what they said, from what I'm interpreting from this article, they said, let's test the baby and the mom for the gene mutation that causes difficulty transporting zinc into milk, because that's a lot more common than the zinc transformer deficiency gene mutation that causes difficulty absorbing zinc into the gut, because that is so super rare. And bingo, that's what they found, not in the baby. The baby didn't have that, but the mother did have that. And then they also tested the zinc level in breast milk, and it was low. They did 10 different samples, and all the samples, it was very low. So the baby was given a zinc supplement, 3 milligram per kilo per day. And within 48 hours, he was a lot better. And at 2 months, his rash was completely gone, and his weight percentile was back on track. And then the zinc supplement, because he doesn't have a difficulty absorbing zinc, we just needed to make sure he got zinc. So when he started eating solids, they switched him from the zinc supplement to a multivitamin. And then he probably was fine after that, after he's, had full solids. Mom was advised that for any future infants, she needed to supplement them with zinc. So a couple things based on this. The authors recommended testing for zinc deficiency in infants who have an eczematous rash that doesn't seem to be improving despite typical treatment, especially if they have other subtle symptoms like, kind of fussiness, not really eating that well, maybe a little bit of growth faltering where it's like, is this something or not? And if they have, hair is always a hard one, right? Because so many babies are bald. So it's really hard to say.
Yeah.
And what's interesting, this baby had symptoms for 3 months before tested, because all of his symptoms were just considered nonspecific until the rash got really severe. So, what they're saying is that if babies are just, to kind of have that thought maybe a little earlier for babies who have this worsening rash, especially when they're not in
Or something, if a baby is having eczema, it's something that it still is worthy of noting in their exam and then cycling back. If their parents are doing everything you're telling them and it's not getting better, expand your differential, like go back to the drawing board.
Exactly. And I think what happens is that it was considered maybe food sensitivity, so the mother went off all these foods, but really at the same time, if fine, they can try that. But usually I have found that doesn't necessarily make a difference. Sometimes I've had moms with peanut allergy, the babies with peanut allergy, and the mom stops peanuts and the rash gets better. But then that's kind of more classic eczema. But
Yeah.
tends to be a little bit different. The other thing that they pointed out is that some infants live on donor milk. They get milk from a donor, like from human milk for human babies or eats on feeds, and the milk gets sent to them and they're eating and they're just drinking that. And in fact, this mother was donating her milk to other families. So that's something to consider.
Oh.
Now, I
So
do want to
donate like informal milk sharing or like
informal,
pooled with other.
informal. Informal. I assume
Oh.
informal because they do mention, which I wanted to stress, that we don't need to worry about zinc deficiency in milk from the Habana milk banks because we pool the milk. And this is one of the most important reasons to be pooling milk because some others have low DHA, some others have low B12, some others have low zinc. And if we pool this milk together, we get an even keel, we get, nutrients dispersed properly, so we don't have to worry about deficiencies. So, but that makes me wonder, like, oh, at some point, should we be doing, nutritional analysis for milk that's donated, for zinc and for B12 and some other vitamins? Who knows? Right now, it really has not clinically been an issue, so it seems like something that we don't need to be doing. And then a final point is whether screening for this gene should be included in the carrier screening that people do before or during pregnancy when people are being screened for gene mutations for recessive inherited disorders like cystic fibrosis, spinal muscle dystrophy, muscle atrophy, and sickle cell disease. So one of the things that they mentioned that when the mother was tested, this mutation came up. And the lab said, oh, this is a variant of unknown significance. And it was just considered like in the junk pile of it's called VUS, variant of unknown significance. But then the medical geneticists were like, oh, wait, that's the one that's associated with zinc transporter deficiency. And so the problem is that when genetic testing is done for people who are either pregnant or for, prenatally for carrier screening, they don't necessarily report these variants of unknown significance or undetermined significance. So I think that needs to be pulled out of that junk pile and needs to be actually screened for, because it isn't, I mean, 1 in 2,000, I mean, that's actually not that uncommon, especially when you look at the frequency of other the genetic metabolic disorders that we screen for infants, right?
Right.
And the fact
And I think
that,
though important though is that if it gets reported though, it needs to go hand in hand with that doesn't mean you shouldn't breastfeed your baby. Just
right,
when you
right,
do, we'll do this as well, but not as a reason not to.
exactly. No, right. And so what they could do is they could even check the colostrum for zinc. So it's just known right away, or even just give the baby a multivitamin with adequate zinc until they find out. But yeah, we do. And that's true for, obviously for things like PKU, for maple syrup urine disease. Yeah, they may need some specialty formula, but of course it's really important to breastfeed, for so many different reasons. Yes, but I mean, there's so many things we get sideswiped in lactation, right? People find out that they have, oh my gosh, I have breast hypoplasia. I don't have enough milk, or I have a really low prolactin level. They find out about this, weeks into lactation when they've been triple feeding their hearts out. And, we need to do better in terms of anticipating and screening and identifying who's at risk, right? And this is
Mhm.
just one of those that is pretty easy. I mean, they're already getting genetic testing. They just need to pick up on this variant and identify it and put it to use. So, yeah, so that's that about zinc.
That's awesome.
Yeah,
The rash is really impressive. It's really impressive when you see the full blown acrodermatitis. Like,
enteropathic. Yeah,
yeah.
yeah, it looks like psoriasis is because you get these really like large confluent patches. Because I've had adults in my practice with psoriasis, and they can have patches that cover like half of their abdominal wall. I mean, they're huge, and that's kind of what it reminds me of. But the authors here are saying like, maybe we're seeing really mild forms of this, and and then it just goes away. And they even said that it's kind of like a thing, which I've never really thought of, but it's kind of a thing that eczema gets better after 6 months. And I've never heard of that. I always think it gets better like after, 2 or whatever. But they said that that's kind of a thing. And then they're saying, well, maybe that's not a thing. Maybe that's zinc.
And they eat cereals and meats, and then everything
gets
just
better. It just gets better. Yeah. Yeah.
So interesting. Well, thanks for sharing that.
Yeah. Yeah. All right. Well, good talking to you, Lena, and have a good weekend. We'll talk again in a month. See ya.
Sounds good. Bye.
Thanks for listening. If you have questions or comments regarding this podcast, please contact us at admin@lacted.org. That's LACTED.org. You can also post comments or questions on our Breastfeeding Medicine Facebook page, and we will have links to our articles on the page. We have boatloads of breastfeeding education opportunities at our website, lacted.org, so come check us out and become a member to join our community.